Hello, and thank you all for joining us for today's webinar. The Pituitary Network Association is a nonprofit organization that relies on the support of our members and donors. We offer this webinar series to help educate patients, their families, and their healthcare providers. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Headaches and Pituitary Tumors, is being presented by Dr. Garni Barkhoudarian. Dr. Barkhoudarian is an assistant professor of neurosurgery and neuroscience at the John Wayne Cancer Institute at St. John's Health Center in Santa Monica, California. Dr. Barkhoudarian completed his undergraduate education at UCLA, majoring in microbiology and human genetics. He attended the University of Michigan Medical School, wherein he was the Edgar A. Kahn Neurosurgery Research Fellow. He completed his neurosurgery residency at the UCLA Medical Center. He then completed a fellowship in pituitary surgery and neuroendoscopy at Brigham and Women's Hospital and Harvard Medical School. Dr. Barkhoudarian's clinical interests are minimally invasive skull-based surgery, pituitary disorders, benign and malignant brain tumor surgery, neuroendoscopy, trigeminal neuralgia and hemifacial spasm, and mild to severe head injury concussion. He is the director of the Brain Tumor Center, Skull-Base, and Endoscopic Microdissection Laboratory. Dr. Barkhoudarian is involved in a number of clinical and translational research studies evaluating the genetics, diagnosis, treatment, and results of patients with malignant metastatic tumors, meningiomas, chordomas, and pituitary tumors. He is also evaluating children as well as active and former NFL athletes with chronic repetitive concussions and brain injury. He has a special interest in the advancement of technologies for minimally invasive neurosurgical procedures. We are now going to turn the presentation over to Dr. Barkhoudarian. There may be a brief delay as we change presenters.
Excellent. Okay, can you see my screen?
I can, yes. All right, it is all yours.
Let me just minimize this a bit more. Sorry for the delay, I'm just making my picture smaller so I can see what I'm going to talk about. Okay, can you hear me okay?
Yes, we can hear you just fine.
Excellent. Well, first of all, I'd like to thank you all for inviting me to speak today at the Pituitary Network Association. It's truly an honor to be a member of this organization, and it really is our goal to try our best to help our patients with all sorts of different types of pituitary tumors, and as many of you know, some of them can be straightforward, but others can be quite challenging. And I think one of the more challenging things that people have been tackling with pituitary tumors is the symptom of headaches. Headaches can be pretty obvious in some cases, and it's very clear that that's related to the tumor or to the lesion that we see. But oftentimes it's kind of a gray zone, and I'd hope to spend the next 45 minutes or so to try to elucidate some light on the issue of headaches as a symptom of these types of tumors. So without further ado, we'll move forward here. As many of you know, the pituitary gland is the master gland. It's really the it's at the nexus of the brain, and it involves so many different systemic structures and organs, involving everything ranging from growth and stress and sexual reproduction, and thirst regulation, etc. But there's also other things that the pituitary gland controls, along with its relationship with the hypothalamus, that's a little bit more subtle, and it's in these subtleties where the difficulties arise in managing some of our patients. The most interesting part from my perspective, from a surgeon's perspective, is its location. It really is deep in the center of the brain, and it lies in the nexus of a number of really critical structures. So obviously the pituitary gland itself is a critical structure, but also the optic chiasm, depicted by this gray whitish gray band here is just above the pituitary gland, and any pressure on the chiasm can cause vision loss, tunnel vision usually. It's right on either side of the carotid arteries, which supply blood to the brain. And just past the carotid arteries are these important nerves that supply sensation to the face and also control eye movement. And of course, there's the brain just above it and just to the sides of it. So any sort of tumor in this region can affect any of these structures, and you can get all sorts of different types of presentations, which actually is one of the reasons why it's so difficult to make a good diagnosis of pituitary tumors in some cases. Here's an example where we move from a normal anatomy in this cartoon, where the optic chiasm and the carotid arteries are well separated from the pituitary gland, and then you have a tumor that grows in this area, and all of a sudden you have pressure on these. And most of the time these are not invaded by the tumor, but at least they're being pushed on, and when that occurs you get dysfunction and various symptoms. Probably one of the more common symptoms people get are headaches, and we're going to spend a lot more time on that. But also it's important to know that people can sustain vision loss or blurred vision, color loss, etc., tunnel vision, many sorts of endocrine abnormalities, either due to overproduction of hormones, as we see in Cushing's disease or acromegaly, or in patients with prolactinomas, or hormone dysfunction, which is the opposite, obviously, which can occur independently of these different types of syndromes. And most commonly, we see a combination of this above scenario, and usually headaches play a role at some level in some of our patients. And I won't discuss the incidental findings, incidentalomas as we call them. Many times, though, people think these are incidental tumors, but they actually may not be. It's just we just haven't really diagnosed the syndrome as well as we had thought. This is a cartoon that I had borrowed from a colleague of mine at UCLA, Bill Young, a pathologist, who actually did a nice job characterizing the different types of structures that surround the pituitary gland. So if this blue is the pituitary gland, we have the covering of the pituitary gland, the meninges, the bone surrounding it, the cerebrospinal fluid that bathes it, the brain, the optic nerves, the chiasm, and the hypothalamus. And at each point in this area, there could be different types of pathology that exist, whether it's a pituitary adenoma, the most common type of pathology there, Rathy's cleft cyst, or more uncommon things like craniopharyngiomas, chordomas, granulomatosis, optic gliomas, etc. So we have to deal with all sorts of different types of diagnoses to figure out exactly what we're dealing with. This is an example in a patient who unfortunately did not survive, but had Cushing's disease and had a microadenoma, very small adenoma, causing her Cushing's disease and resulting in her demise. This was taken about 50 years ago by Jules Hardy, and that's a good example of how significant even a small tumor like this can affect a patient with that disorder. This, on the other hand, is a patient who, again, many years ago, who had a very large pituitary adenoma, and this, even though it wasn't secreting any hormones, caused problems because it grew so large that it ultimately obstructed the normal flow of cerebrospinal fluid and developed hydrocephalus and then slipped into a coma. And so thankfully we don't see this at common, but these are kind of the extreme situations of pituitary tumors and how they can present. There's all sorts of other types of tumors, Rathy's cleft cyst, dermoids, craniopharyngioma, meningiomas, epidermoids, schwannomas, and chordomas, and they all occur at different areas or regions surrounding the pituitary gland, around the sella, which is the home of the pituitary. And each of these tend to present in a somewhat of a unique way, and we'll touch upon some of these in the next few slides. So just to kind of start things off, I wanted to discuss how we define headaches. And believe it or not, there's an entire society dedicated to headaches, and in the International Headache Society, and they have categorized every single type of headache you can think of, including headaches that are associated with brain tumors. So this is their criteria, and basically they say a headache with at least one of the following characteristics and fulfilling C and D. So C and D down here. So at least it being progressive, localized, worse in the morning, or aggravated by coughing or bending forward. you'd want to see an intracranial neoplasm on the imaging, although it's not always there. At least it's not always visible. And then the headaches develop usually in a temporal or spatial fashion related to the neoplasm, basically meaning that as the tumor grows, the headache gets worse. And then here's the catch, though. The last comment states that the headache must resolve within 7 days after surgery for removal of this lesion. So it's kind of circular logic that, yes, you have a headache related to a tumor, but the only way to really prove it is by taking it out and seeing if the headache goes away. Well, that probably would result in many unnecessary operations in patients. So it's our job to try to figure out which patients' headaches are actually related to their cyst or tumor, and which patients we may be able to treat medically and not need surgery. This is a study from a while ago looking at the different locations of headaches associated with different types of tumors. And this is back, I believe, in the 1950s when this was published, talking about the location of a headache in this region in the temples associated with middle meningeal artery, on the top of the head associated with the sagittal sinus, on the forehead and the orbit, and associated with all these different structures. And then this does include the cavernous sinus and the pituitary region. So this is, they've already known that 50, 60 years ago when this was published. We'll talk a little bit more about the location of the headaches. This is a study that came out about 15 years ago, and basically they looked at about 280 patients over a period of time with any sort of brain tumor, and they just wanted to see what are some criteria that would be associated with headaches, just to kind of get a sense of what really correlated with headaches. So these are all sorts of tumors, not just pituitary tumors. And of all comers, 60% of patients had headaches. And of the patients who did have headaches, 15% actually had persistent headaches after surgery. So we would categorize this as headaches that were not related to the tumor itself. And that suggests that about 85% of patients who had headaches related to a brain tumor got better after surgery, suggesting that their headaches were related to the brain tumor directly. So that was the start. Now they decided to examine this a bit more carefully. So they looked at patients who had progressive headaches versus non-progressive headaches. And in patients with progressive headaches, those that had more of an aggressive type of tumor, like a metastatic brain tumor or a glioblastoma, were statistically significantly higher risk of getting progressive headaches. Whereas people who had kind of static headaches, that they've always been there for many, many years, these non-progressive headaches, the most common tumor was a benign type of diagnosis, a meningioma. These are slow-growing tumors. So it was an interesting difference between the progressive and the non-progressive headaches. Also the location. If the tumor was above what we call the tentorium, so above into the cerebrum of the brain, these patients typically had lower chance of presenting with headaches, as opposed to the tumors that were lower down in the skull base or in the cerebellum. Those patients had a much higher rate of presenting with headaches than their other counterparts. And interestingly, if there was a tumor in the ventricle, which is in the fluid-filled areas of the brain, these patients actually had a notable higher rate of presenting with headaches. Now there's other criteria that we will talk about down the line that could contribute to a progressive headache. And the key one is the development of mass effects in addition to the tumor. So say the tumor is obstructing the normal cerebrospinal fluid flow and the patient gets hydrocephalus, well, these patients definitely have a higher risk of progressive headaches. And also, if there's any midline shift, so enough pressure on one side of the brain that it's shifted over to the other side, which we see from time to time even in pituitary tumors, then these patients could develop progressive headaches. And these are more serious types of tumors that we'd want to deal with. So what are the typical symptoms associated with headaches from pituitary tumors specifically? This information was gathered by my work with Dr. Ed Laws and his team at the Brigham and Women's Hospital, basically asking patients who've had pituitary tumors what type of headaches they had, their severity, etc. And we found that most patients had daily headaches. They're typically bifrontal, meaning in the front forehead region or behind the eyes, or they were at the vertex or the top of the head. They generally lasted 1 to 4 hours in duration, especially at their most severe status. They could be unilateral. They could be only on one side. It didn't necessarily mean it had to be on both sides to generate a headache. And in general, the patients complained that these were moderate or severe headaches. They weren't kind of mild, forget about it headaches. They were definitely interfering with their lifestyle. In a minority of patients, about 15% of patients, they would wake up because of or with the headache. And that was actually a key finding because that usually suggests that something a little bit more aggressive is going on in the brain. And in rare cases, but notoriously, one could develop really sudden, severe onset headaches. And when we hear that in the setting of a pituitary tumor, we have to be concerned that there was bleeding into the tumor, and a condition called pituitary apoplexy can occur. And we'll talk more about that. But the key point is, in that setting, you don't want to sleep on it. You don't want to take a bunch of aspirin. You want to go straight to the emergency department because this is a surgical emergency until proven otherwise. So, what are some of the mechanisms that we think can contribute to the headaches? And we'll talk more about this in depth. But in this slide, I wanted to point out that you have a large cystic lesion here. This is an arachnoid cyst or Rathke's cleft cyst, and it's pushing and stretching the normal contents of surrounding the pituitary gland. And we think that this is the #1 mechanism of headaches, meaning that the dura mater is being stretched, and the nerve fibers that are on the dura mater, because the brain actually doesn't have neurofibers, it's actually on the coverings of the brain and the pituitary gland, those, when they stretch, generate headaches. Interestingly, though, larger tumors are less likely to cause headaches because they generally tend to be slower growing, and the brain can accommodate and the nerve fibers can accommodate, and they don't generate the pain signal that you'd expect. Cystic lesions like Rathke's cleft cyst, arachnoid cyst, cystic craniopharyngiomas, or cystic adenomas tend to be more likely to present with headaches because we think that the cyst is expanding at a different rate than the rest of the tumor is. And of course, as I mentioned, if there's bleeding into the tumor, if there's hemorrhage or apoplexy, then there's a higher rate of headaches. This was a breakdown of our patients who did have headaches, and you can see in these patients we looked at their typical headache and their most severe headache. And in patients with macroadenomas, their typical headache ranged at about 3 or 4, and their most severe was about a 5. Same with the microadenomas. But patients with cystic lesions had consistently a higher average rate, higher severity of a headache. So again, pointing that cystic tumors tend to cause more significant headaches. This is a study that came out about 10 years ago looking at pituitary volume and headaches, so characterizing the volume of the size of the tumor. And it's interesting that they've concluded that the size was not the only factor contributing to the headaches. So they looked at 63 patients. 70% of these patients had headaches. And this is their scatter plot, basically plotting the tumor volume measured in milliliters with the headache score that they had compiled. And you can see there is no linear or logarithmic correlation associated with this. It's completely random. You can have very, very large tumors with very low or no headaches, and you can have very small tumors with significant headaches. So there's a wide range that we're looking at here. They did note that if a tumor was invading some of the nearby structures, so the cavernous sinus, which is where those the carotid artery lives and those veins and those nerves live, as I was talking about earlier, these tend to have a higher rate of headaches. And is the patient already prone to headaches? So if there's a family history of headaches or if there's a history of migraines, there's a higher rate that that patient will generate a headache related to the tumor. This is the data that they published after surgery. So whether it was through the nose, through the brain, or just radiation, they found that 23 patients did improve, 8 actually got worse, and 19 really didn't change much. So about a little bit less than 50% of patients were either were better, and only a fraction were worse. Now here's the interesting part. In a number of these patients who had hormone-secreting tumors, so say acromegaly or Cushing's disease, when they were treated for their hormone secretion alone, so just sandostatin or octreotide or lanreotide, their headaches all got better. And also in patients with prolactin-secreting tumors who were treated with cabergoline or bromocriptine, their headaches mostly got better in this population. So there's definitely a correlation with hormone secretion and headaches, particularly in the acromegaly and Cushing subgroups. And we think that there is a direct relationship with the syndrome and the headaches. So basically, their conclusion was that 50 to 95% of patients could respond to surgery, at least with some improvement of their headaches. And in their series, they thought that the best improvement occurred in arachnoid cyst patients, Rathke's cleft cyst patients, patients with pituitary apoplexy, and resolution of the hormone secretion. So now I'd like to switch gears just a little bit and talk about some of the mechanisms we think about in a little bit more depth with regards to the development of these headaches. We talked a little bit about this already, but the direct dural stretch is one mechanism that we feel is the most likely cause of these headaches. But also there's structures nearby. So the trigeminal nerve, which is the nerve that supplies sensation to the face and lives in the cavernous sinus, they can get irritated, and you can get a syndrome called trigeminal neuralgia, a different type of headache, more like a facial pain than a headache. If there's inflammation surrounding the lesion, so if it's an infection or inflammatory process, that itself can irritate the dura and cause headaches. And if there's increased intracranial pressure, either due to direct mass effect from a very large tumor or due to hydrocephalus, which we mentioned earlier, that in itself can cause headaches in addition to the tumor being present. And then if there's any bleeding directly into the tumor, there's just a sudden increase in this volume of the tumor, that can cause headaches as well. So we'll talk about all of these. So as I mentioned, direct dural stretch essentially can occur anytime you have deformation of the normal structure. So the dura, which is this layer here that I'm tracing, covering the pituitary gland, the cavernous sinuses, which is these blue blood-filled areas, as well as the nerves that go to the eye and to the face. Well, as we saw this in this figure before, when this gets stretched, the nerves get irritated. This is a diagram of the different parts of the trigeminal nerve as it innervates the head, which is, many people are already aware of this, that most of the facial sensation is innervated by the trigeminal nerve, a cranial nerve. But this is the inside. This is on the inside of the brain, and the pituitary gland lives right there, right where my arrow is. It's called the sella turcica, and the pituitary gland sits right there. And this entire area is innervated by the first branch of the trigeminal nerve. So if you come back here and you see that the first branch, the V1 branch of the trigeminal nerve, is innervating the eye and the forehead. This is the most common location of the headaches, as we had mentioned, for pituitary tumors. Also, it goes up to the top of the head, which is at the tip of it, of the nerve extension, and that's also another common location. So these are all related to the location of the pituitary tumor. Sometimes, however, the pituitary tumor won't just stay here and will go into the posterior fossa, which is this purple area back there, or out sideways, and you'll get pain that refers out to the cheek or towards the back of the head as a result. And you can see the back of the head here, or the cheek area is there. So here's an example. This is obviously not the same patient, but here's an example of a patient with a microadenoma, as we had shown before, that grows into a large macroadenoma as it progresses. And you can see how the dura will get stretched to the point where you would expect it to cause some headaches. Not all the time, but sometimes. This type of lesion is actually a cyst. So this is a Rathke's cleft cyst, and I know that because it's splitting the anterior pituitary gland and the posterior pituitary gland. And we see here that the Rathke's cleft cyst can quickly get large, quickly meaning over a few months or years, but still it can enlarge and cause stretch into this area, and you can already assume that there's going to be some stretch of the pituitary gland. These cysts can occur within the pituitary gland or above it, up along the course of the infundibulum, or the connection of the pituitary gland and the brain. This is an example of a patient who had a headaches related to a cyst above the gland. And here we are in surgery, and you can see that there's a little bit of bowing through the dura. The dura is a bit stretched. We cut into the pituitary gland, which is a common way of getting into this area, and we drain this Rathke's cleft cyst, and the headaches subside because the dura, which is above it, stops being stretched. And here you see after surgery. This is a patient with an arachnoid cyst. The fluid matches the cerebrospinal fluid within the cyst and surrounding the brain. And essentially, this is a CSF leak within the pituitary gland, and the CSF is pushing into and is stretching the pituitary gland. So it's under a decent amount of pressure. And just by draining this, we're able to move forward here. Just by draining this, we're able to decrease the pressure. So this is a similar patient. This is bone that you're seeing. So the bone has actually been thinned out by this process to the point that it's eggshell thin, and we can easily enter it with a soft instrument or a blunt instrument. And we're able to open and expose this area. As we move forward, we enter the, I'm going to speed this up here, we enter and we see as soon as we enter the cavity, the fluid gushes out, and we're going to introduce the endoscope into the cavity, and you're going to see at the top the area where there's a communication with the brain and the pituitary fossa, and you can see there's going to be some fluid coming from just this area right up here in the top left of the screen. You'll see a small amount of fluid coming out, and that's why this patient is developing this cyst, and as a result these headaches, because there's a direct communication in that area. So all we need to do is obliterate that, and the cyst will not reform, and the headache should resolve over time. Well, trigeminal neuralgia is another condition that I treat. And trigeminal neuralgia is a syndrome where the trigeminal nerve is irritated due to various reasons. And the first thing we think about when we see a patient with trigeminal neuralgia is to make sure that there aren't any structural lesions causing pressure or invading the trigeminal nerve that would result in pain. And so we get an MRI, and many times, well, a number of times, we identify a tumor in the area that could be pushing on the trigeminal nerve. However, numerous times we don't see that, and we have to look at other causes. But the symptoms of trigeminal neuralgia are a bit different. It's basically severe stabbing or lancinating pain, so this shooting pain down the face that could be triggered by something as simple as touching the face, chewing, brushing your teeth, or even air or wind touching the face can trigger this intense pain. So it's pain out of proportion to the stimulus. And it's typically responsive to drugs like carbamazepine, which is Tegretol, or other anti-seizure drugs or anti-epilepsy drugs. However, in some cases it doesn't really respond well. If we've ruled out other causes, then we wonder if there's a blood vessel that's sagging and pushing on the nerve there, which is one of the more common types of treatments for this. Essentially what that does is it irritates the nerve, and it causes a short circuit, what's called ephaptic transmission of the trigeminal nerve, and it allows for any sort of sensation to be interpreted as pain by the brain. And this is an example of a surgery where we're looking down in this area, and you can see this white band right there in front of the brainstem. That's the trigeminal nerve, and there's an artery right there, and it's indenting and pushing into the trigeminal nerve, irritating it every time it pulsates, and resulting in the pain that the patient is experiencing. So in this type of operation, we would separate the artery from the nerve by putting in different types of substances, generally Teflon, to separate the trigeminal nerve from the surrounding structure. So here you see an endoscopic view of the trigeminal nerve and the arteries running right along it. And all we do is put a little bit of Teflon, there we go, and secure that into place. And the Teflon will prevent the artery from touching the nerve, and the patient's pain is most of the time improved by this. About 90% of the time this works when we see an artery touching the nerve. Well, as I mentioned before, sometimes it's not an artery touching a nerve, sometimes it's a tumor or a lesion along the nerve that could be the culprit. So this is an example of a patient with a right-sided, the images are flipped, a right-sided facial pain and a right-sided lesion that's in this area where the trigeminal nerve lives, called Meckel's cave. and it's extending towards the brainstem. So this is a patient who really only has pain in the face. And we operated on this mainly to make a diagnosis, and if it is something benign that should be removed, to remove it completely. And here we have our exposure, and you can see this is where the pituitary gland lives, up in the top left of the screen here. This is the carotid artery that supplies blood to the brain, and it's actually going sideways and upwards here. And this is the covering of the nerve as it's coming over the hump as it goes into the face. And you can see the little fibers of the nerve coming through, and just behind it we see the solid structure here. And that solid structure is the lesion. So we cut into it and we biopsy that. And in this patient, that biopsy proved to be, I believe this patient proved to be a granulomatous process. So it basically is an inflammation of the nerve itself. And that became a big mass, and that was pushing on the nerve. And just by diagnosing that, we were able to get her on the appropriate treatment, and her lesion got smaller and her pain went away. Well, other things could also irritate the nerve, such as other inflammatory conditions like sarcoidosis or Wegener's vasculitis, temporal arteritis, or even surgical products that we put in there at the time of surgery can irritate the nerve. Well, meningitis is definitely one of these conditions, and we had a patient come in with pretty severe headaches, nausea, and vomiting, and the CT scan showed a large lesion, but nobody really investigated that she had been having low-grade fevers, and they just started her on steroids, and she got a little bit better, but actually then took a turn for the worse, and it came to our hospital in frank meningitis. And the meningitis was actually the cause of her headaches. She had this very large tumor, and it actually had been associated with a cerebrospinal fluid fistula or leak, and that was a conduit for bacteria to enter into the brain. And this is these are her findings, and she actually had an elevated white blood cell count of her blood. It's quite significant, low sodium level, and multiple pituitary hormones were affected. We were able to treat her meningitis, which was somewhat profound, and once we got that under control, we made a diagnosis of chordoma, and we went forward with surgery. And this is an interesting finding. Well, we see the tumor in this area here, but we also see evidence of meningitis on the diffusion-weighted image of the brain along the surfaces, which is not a common finding, but it is concerning and requires urgent management. And this is her operation here, and you see that she had a large tumor in this area. We've already removed much of it, and there's just the part that's knuckling into the brainstem, and this is the part that we carefully debulk. And I'll just speed this up in the interest of time, and you can see there's a tumor that remains as we're working in this area going towards the spine, the brainstem, and we carefully remove as much of this tumor as we can safely. In her case, it was somewhat stuck to the brain, and we didn't want to damage the brain, so we removed as much as we could, and we left a little coating behind just so that she would have normal function as she would wake up. But after surgery, she actually did well. Her headaches got better, her meningitis improved. Now that we have a seal preventing cerebrospinal fluid from leaking, and we were able to get her back to her daily life. But this is another example of inflammation of the dura. So this normally should be a thin white line, and you see it's much thicker, and you see a large lesion here that's quite bright in the pituitary gland region. And this is a patient with sarcoidosis, so another inflammatory condition in this area. This is a patient that I took care of who had Wegener's granulomatosis, another inflammation. And this interesting situation was that not only did the pituitary gland get inflamed, but the nerves to the eye, the optic chiasm, got inflamed. And that actually caused the patient to lose vision until we were able to treat her with pretty significant high-dose steroids and rituximab, and we were able to get her lesion to shrink and her vision to improve. And second to last is the topic of hydrocephalus. So hydrocephalus essentially translates to water on the brain, and basically it's a result of dysfunctional cerebrospinal fluid circulation. We have called it many things here. This is a hydrocephalon, not to be confused with hydrocephalus. Essentially, what happens is you have the normal fluid-filled cavities of the brain, and they are constantly making fluid and allowing it to flow from this area here to this third ventricle here, down through this little aqueduct, through the fourth ventricle, and it comes out through these holes here, the 3 holes here, and it bathes the entire brain and spinal cord, and then gets absorbed by the blood vessels at the top of the brain. And this gives the brain some buoyancy, keeps it from being moved around too much, nourishes the brain, it allows for the nerves to work well, and it's a very important part of the brain physiology. However, if you have a blockage either within this system or in the absorption of the fluid, then this will all back up and get larger because, as I mentioned, there is no off switch. This is called a choroid plexus because it looks like coral in the water, and it is actually producing the fluid in that area nonstop. This is what it looks like underwater. And so anytime you have a blockage anywhere along this flow, we would worry about hydrocephalus. The fluid that is made is bathes about the entire brain, 25 milliliters of which are just in the ventricles. Most of it are actually bathing the brain. It is made continuously. You make about 20 to 30 millimeters per hour as an adult, and you make about 600 milliliters per day. So the brain will make 3 or 4 times the fluid it needs per day in this area here. It relies on a sodium-potassium pump, relying on ATP to pump it across, and it utilizes the carbonic anhydrase enzyme to convert the water in the CSF side. So that's a target that we can utilize because acetazolamide, which is a diuretic drug, can be used to inhibit carbonic anhydrase and decrease CSF production, although it's just a temporary effect in most patients. There are some other drugs that can work, but this is really the only drug that's been shown to help decrease it a little bit, but not significantly so. So in general, the thing to remember is that there really is no off switch with this system, and the brain is not smart enough, ironically, to know that it needs to stop doing that, and it hurts itself in the process. Just an aside, years ago I went to France with Bob Bartlett from University of Michigan and our Victor Vaughn Medical History Group, and we got to visit the catacombs beneath the streets of South Paris, where we saw famous people's skulls and bones buried there. But we also went to the museum in the Pasteur Institute. We saw these skeletons, and these skeletons are unfortunately children that passed away because they had hydrocephalus, and you can see their heads are quite large and quite blown up there. And it's because the skull actually accommodated to the excess fluid there, which cannot happen in an adult. But it's eerily similar to some of our favorite Hollywood characters here that we've seen, and this is probably a true patient with hydrocephalus that they call as an alien in Roswell. But going back to more serious topics, the way we would treat a patient with hydrocephalus is one of 2 options. Either we shunt the fluid, so we put in a catheter into the fluid-filled areas, the ventricles of the brain, connect it to a valve underneath the skin, and tunnel this tubing all the way down into the belly or other structures in the body to absorb the fluid. And that generally will take care of the excess pressure that this is exerting. And this has been used for 50, 60 years now. The other option is to perform what's called an endoscopic third ventriculostomy, which basically is kind of like an internal shunt or a bypass connecting the inside and the outside of the brain. And this is only useful when you have a blockage in that original system, as I had mentioned. So if you have a blockage, say here or here, then you can create a perforation at the floor just behind the pituitary gland, and the fluid will flow through this area and will decrease the hydrocephalus in this area. Well, obstructive hydrocephalus can contribute to these headaches, as we talked about, particularly with patients with craniopharyngiomas, because they tend to grow into the third ventricle. And depending on the acuity, we may need to treat that urgently first before we do the surgery for the craniopharyngioma or other offending lesion. So this is a patient that we took care of who actually had been treated in another facility, had a large lesion that was proven to be a craniopharyngioma. They approached us with a craniotomy, and they actually put in a shunt at the same time to treat her hydrocephalus, which she had at the time. So she came in. Unfortunately, her wound had broken down, and we had exposed hardware, so we were obligated to remove the shunt, and we put in a catheter to manage her pressures. And then we went through the nose, and we debulked some of this tumor, and we connected the fluid-filled areas, the ventricles, to the rest of the brain region, to the subarachnoid space. And that actually relieved her hydrocephalus, and she didn't even need the ventriculostomy tubing or a shunt anymore, so she was able to become shunt-free. So that's a third way of managing it, is to just remove the offending lesion as best as possible. And she actually did well. We treated her with radiation, and her tumor actually shrunk and is well controlled. This is a good example of a patient that we saw, and I asked this to some of our students, what is the most common missed lesion in the brain? And the answer is the second one. The patient has a pituitary adenoma causing pressure on the optic chiasm, but also has a colloid cyst causing significant hydrocephalus. And in this patient, the treatment that we opted for was to first remove this colloid cyst because it was causing hydrocephalus before we treated the pituitary gland, which is causing hypopituitarism. And we were doing that because we didn't want to have a scenario where the hydrocephalus resulted in excess pressure, and if we had a cerebrospinal fluid leak, it wouldn't heal well. So here we are into the ventricles, and you can see this choroid, the coral-looking structure that's making the fluid. And I'm just going to fast forward through much of this, and we're able to remove the cyst, which is hiding behind this vein in this region here. And by opening this up, we create an opening into this cavity here, which is what's called the foramen of Monroe, and allowing us to decompress the area well. And here we see, once we complete, we can see into the third ventricle, and we have a good decompression. And the patient actually did well without any worsening of his hydrocephalus. And then we went on to take out the pituitary tumor, and he's been recovering well since then. And finally, I want to leave you with the concept of pituitary apoplexy. And of all the types of headaches that we are discussing today, this is probably the most concerning, because not only is it a bad headache, but it could be life-threatening or sight-threatening, both of which we want to address right away. So this is an example of a 43-year-old man who woke with acute, sudden onset, left eye blurred vision, and a sudden onset headache. And his vision actually had gotten a little bit better since that episode, but we saw him and we recommended him to undergo urgent surgery because he had notable vision loss and hypopituitarism, and you can see here the visual fields were affected by this lesion. And he had hypothyroidism, slightly elevated prolactin level, and you can see here a pituitary adenoma with hemorrhage inside it. This dark area is blood that had bled into the tumor area. And so we were able to decompress this patient, and he did well. This was a study from recently looking at the different presentations of patients with pituitary apoplexy. And I don't know if you can see this well, but a number of different conditions we think can precipitate it, including high lipids or hypercholesterolemia. Some people think dopamine agonists can actually cause this. That's a controversial statement. Some of the presenting symptoms, headaches are common. Oculomotor palsy, so meaning double vision because the eyes aren't moving well, is actually very specific to this type of condition. And then hypopituitarism, so low thyroid, low growth hormone, low cortisol, and in general, overall, could be associated with pituitary apoplexy. And long term, we find that some people respond well to early surgery, and unfortunately some people have delayed surgery, and in those cases we end up with more of some of the adverse effects of this. So if surgery is delayed, there's a higher rate of visual loss, visual field loss, which is statistically significant. And we think there may be a little bit of a higher rate of hypopituitarism, although this wasn't statistically significant. So this is that patient with pituitary apoplexy here, and I'm going to speed this up as well. As we enter into the covering of the pituitary gland, you see that that's the gland, and you see that it's quite vascular. And when we enter into this area, you'll see that there's some blood products that will spill out with a necrotic tumor. Much of this tumor is necrotic in this area, and there is some blood that spills out from the cavity where the patient had bled. And so we move forward and we remove as much of the tumor as we can safely. Here we are. And now we're looking at the pituitary gland separating from the rest of the structures here, and we seal that up with fat and collagen sponge. And the patient did well afterwards, after surgery. And this is his visual fields at 2-month follow-up that showed that his vision actually had improved despite his sudden onset headache, sudden onset symptoms. So in pituitary apoplexy, the most common symptoms are a sudden onset headache. They usually say it's the worst headache of my life. It's like a gunshot to the head. Typically associated with vision loss, usually tunnel vision or bitemporal hemianopsia. Hormone dysfunction, so there's this extreme fatigue. You just can't get out of bed. You're very ebulic. That's a warning sign on its own. And other neurological deficits, so double vision, facial pain, numbness, etc. If any of these occur, even in somebody who we are monitoring their benign tumor, we've offered not to operate, this is a surgical emergency and needs to be dealt with right away so we don't have permanent vision loss and permanent hormone dysfunction. So to summarize, I think the take-home points of this talk are just be aware of headaches that occur when you're waking up. Those tend to be associated with more aggressive disease in general. Be aware of progressive headaches, because not only could they be associated with more aggressive tumors, but they could be associated with hydrocephalus or cerebral edema or cerebral brain swelling in the area. Size is not everything, and hormone resolution actually can help with headache treatment. Tumors with cysts or tumors with hydrocephalus are typically respond well to surgery as far as headaches are concerned. And as I mentioned, resolution of hormone hypersecretion can be associated with improvement of the headaches. And with that, I'll leave you, and I'd be happy to answer any questions that you may have. Thank you.
That was excellent. Thank you. Okay, we do have some questions. The first one, is it all headaches that resolve completely 1 week after surgery? My spouse had surgery for a pituitary adenoma, and the headache lasted up to 3 weeks after surgery. She had a spinal drain put in after surgery due to a leak.
So the definition by the International Headache Society was 7 days. That is an arbitrary number. That is not how these headaches actually resolve. I would say a typical headache that is directly associated with a pituitary lesion takes a few weeks, 2 or 3 weeks to resolve. In your case, it sounds like you had a confounding issue with having a spinal drain, and spinal drains alone can cause headaches, so that may be muddying the water a little bit. But I would say a few weeks is generally a reasonable amount of time. And I only really get concerned when the headaches are still present at about 2 to 3 months. And in that case, we want to look at other causes, make sure that the sinuses are clean, there's no sinusitis, make sure that the pituitary region is stable. We usually get a new MRI at that point, and then obviously rule out other causes of headaches.
Okay, what is the prognosis of relapse of an atypical pituitary tumor with a mitotic index greater than 2?
Well, it's a little bit different topic. So we're talking about an atypical pituitary adenoma. Generally, the recurrence rate is a bit higher than a typical pituitary adenoma. A typical adenoma recurrence rate is about 8% in 10 years. An atypical adenoma recurs or progresses about, depending on what study you read, 15 to 30% in 10 years. So it's 2 or 3 times as likely to recur. The other point is, and this was a study that came out about 2 years ago, that it's not just the grade of the adenoma, it's also its invasiveness. If you have a atypical adenoma, it has a certain rate of recurrence. If you have an invasive adenoma, it has a certain rate of recurrence. But if you have an atypical invasive adenoma, these are a lot more aggressive, and these tend to recur or progress, and it's very hard to achieve remission. And these are patients who we would recommend very close follow-up and probably adjuvant therapy, either radiosurgery or even temozolomide has been used in some of these cases. But it's not just the pituitary grade that's key, but also its invasiveness. And sometimes it's hard to differentiate that on a pathology slide because the pathologist only gets the meat of the tumor, so you have to look at the imaging and see if there's any invasion on the imaging. And if you're lucky, the pathologist will get some dura, or the covering of the pituitary region, and that will actually help diagnose invasion as well.
Okay. Can high IGF-1 cause headaches?
Yes, so based on that study that I showed, high IGF-1 definitely can cause headaches. The mechanism for it is multiple. It could be due to a TMJ. It could be due to sinus obliteration, because these patients with acromegaly tend to have beefier sinuses and sinusitis sometimes, or at least allergic rhinitis. And there's also some of the bony aspects. So if you have significant neck pain, that can also translate to headaches as well. So there's numerous causes for headaches with patients in patients with acromegaly, and as I showed you in that slide, many of these patients who were treated with even just somatostatin analogs did improve in their headache severity.
Okay. Can small microadenomas cause headaches too?
So in our series that we looked at Brigham Women's Hospital, we did not find that was a correlative event. Typically, patients that we've operated on with microadenomas had another process going on. Either they had a prolactinoma that was refractory to therapy, or they had Cushing's disease, rarely acromegaly. And in those cases, if it were Cushing's disease, we would say the reaching remission would actually help with the headaches. Prolactinoma is a little bit 50-50 with regards to response to headaches. And then the other thing to remember is many patients get MRIs just because of the headaches, and we see these small adenomas. So it's very likely that it could have been an incidental adenoma that we identify. And this is where it's really key to be a bit more conservative, to really characterize the headaches, to get multiple images and see if that tumor grows, and if the headache changes at all with relation to the size of the tumor or with relation to the severity of the headaches. Does the tumor change? And those are some factors to think about, because there's definitely a Venn diagram overlap of patients with headaches and patients with pituitary tumors.
Okay, thank you. Because of the gut-brain connection via vasovagal nerve, is there any literature suggesting a connection between post-gastric bypass and/or lap band and later development of pituitary tumor or dysfunction causing headache?
That is a very good question, and I have not heard of that. I have not seen that in our literature. The vagus nerve actually is a little bit separated from the pituitary system. It's more controlled at the brainstem level, so it would be hard to create a link there. But I have not seen that in our literature.
Okay, thank you. If pituitary gland has been totally removed via surgery and regular blood work is done, how can anyone determine what normal levels are in such a patient? How can their levels be compared with charts used for patients with no known maladies?
So we're talking about the hormone levels?
I believe so, yes.
So oftentimes we still go by normal levels in patients who don't have pituitary lesions, and we'd want to see at least the cortisol levels and the IGF-1 levels to be similar to patients who did not have pituitary tumors. Of course, age and gender match. Some of the challenges I think we see are in patients who have hypothyroidism, because the general public treats hypothyroidism by looking at the TSH, the thyroid stimulating hormone level. But in patients with hypothyroidism due to a pituitary lesion, or who may have had both, you cannot follow that hormone anymore. So you actually have to follow your patient's symptoms as well as the T3 and T4 hormones. Those are the active and pre-active thyroid hormone levels. And those would be the hormones we would monitor. And that's a key difference in a patient who does not have a pituitary tumor and has hypothyroidism, where you would just follow TSH. The other hormone that gets a bit altered is prolactin, particularly in patients with a very, very large pituitary adenoma. We looked into this briefly, although it hasn't been published, but we think there's a correlation with very, very low prolactin levels can correlate with pituitary dysfunction. So a low prolactin level after surgery is a bit deceiving compared to a low prolactin level before, but then the question is, does it even really matter? So it really doesn't affect our patient care in the long run.
Okay. Can an enlarged paraventricular space mean anything when a person suffers autonomic dysfunction and has family history of meningiomas, pituitary tumors, and interventricular cysts?
It's hard to say, because now we're talking about kind of a chicken and the egg situation. One would say, do you have large ventricles because it's causing pressure, and is it causing pressure on the surrounding brain structures? Or do you have large ventricles because the brain is atrophying because of another process, like Shy-Drager syndrome or something that would cause vasomotor a dysfunction? And that would require an evaluation by a neurologist who specializes in these to make sure there isn't something else going on. However, there's some criteria that we use to see if the ventricles are out of proportion to the size of the brain, and if you reach some of those thresholds, you say, oh, maybe the ventricles are causing some of those problems. And there's a syndrome called normal pressure hydrocephalus that can result in some symptoms of cognitive decline, incontinence, and gait difficulties. But usually you'd want to see some of those in a triad before treating that syndrome with a shunt.
Okay, and the same person also commented, I meant a small 6 millimeter Virchow-Robin space in the basal ganglia, to clarify.
Oh, that's something different. That would be hard to say. I'd have to look at the films to be certain and characterize the vasomotor dysfunction. But generally, Virchow-Robin spaces are thought to be something we wouldn't treat for sure, and maybe sometimes not even related to the pathology being seen. So it really needs to be evaluated by a neurologist.
Okay. In the presence of persistent, progressive, localized headache in the absence of hormone abnormalities on initial standard tests, enough of a reason for evaluation by an endocrinologist versus just staying with a PCP internist?
So what's the question? Is the question to be evaluated by an endocrinologist versus
right. Versus primary care?
Probably you should discuss that with your primary care physician. Sometimes there are some subtle differences in the hormone levels, or not all hormones are being assessed. So that may be a reason to talk to an endocrinologist, particularly somebody who specializes in the pituitary gland. But I would want to know a little bit more about the condition, and also if there's any abnormalities in the pituitary gland, and what are the general symptoms.
Okay. I was diagnosed with a 4 millimeter pituitary microadenoma. I have the frontal headaches you mentioned, and often they are severe in nature and cause vomiting and mimic the description of a migraine, sensitive to light. My endocrinologist has simply advised me to wait and be rescanned in a year, although I have hypopituitarism and the headaches pressure in my head. Would you suggest a second opinion? If so, is there a different type of doctor I should be seeing other than an endocrinologist?
It sounds like the endocrinologist is correct. Headaches with nausea with a very small pituitary microadenoma is probably not caused by that microadenoma. It's too small to even cause pressure in the area. If your hormones, if you don't have hypersecretion syndrome like Cushing's disease or acromegaly, then I don't think that's related to your headaches. I would stick with your endocrinologist to treat your pituitary dysfunction and re-image in a year, as mentioned, and have the migraines treated by either your primary care doctor or a neurologist.
Okay. Could nystagmus in one eye mean a compromise of the optic nerve from a 9 millimeter non-secreting adenoma?
So nystagmus in one eye or nystagmus in one direction? I think
In one
generally
eye.
nystagmus, it's
Says in one
you
eye,
see
but
both eyes. But assuming that's the case, generally nystagmus is an issue of either the brainstem or the nerves coming out of the brainstem, specifically the vestibulocochlear nerve, that would control the balance issue, balance side of the brainstem, and then it relays that to the eye. So the nystagmus is actually generated down in that level. The nerves that are coming past the pituitary adenoma that you're discussing are more just relaying the information. They don't generate the nystagmus. So I don't think that's generally the case. We'd have to look down at the brainstem, and you'd want to have an ENT or ear, nose, throat physician evaluate you for your nystagmus as well.
okay. I had a question that I received actually prior to the webinar, so you may have discussed this a little bit, but I wanted to know if you had encountered any cases where pituitary tumors had caused headaches that manifested as trigeminal neuralgia pain. I was diagnosed with atypical trigeminal neuralgia, constant for hours once the onset began rather than intermittent bursts of a few minutes. Years before my tumor was finally diagnosed, my research indicates that the nerve root for the trigeminal nerve, cranial nerve, fifth ventricle, is directly behind the pituitary, so it seems to me there must be some sort of connection. Also, if they do know of or have experience with this, is there any particular clinical significance associated with it?
So we did discuss it as you mentioned, so I'm glad we talked about that. But I'll summarize in short. Generally, a pituitary tumor in the center, in the pituitary gland itself, should not cause trigeminal neuralgia. It's usually tumors that are over to the side, that are either in the cavernous sinus, which is right next to the pituitary gland, or down into Meckel's cave, which is where the nerve is actually exiting the brainstem. And in those cases, you could get trigeminal neuralgia. So if you have an invasive pituitary adenoma into the cavernous sinus or pushing on the cavernous sinus, that could be related. I don't know if you've had surgery and what your diagnosis is exactly, but it's very hard to predict clinical significance based on that, other than if there is compression, then potentially surgical removal can help with the pain. But one would really have to carefully look at your imaging to make sure we coordinate that well.
Okay. If a patient has many of these systemic symptoms, meaning daily debilitating headaches, fatigue, in addition to sudden onset hypopituitarism, vision loss, and vision disturbances, along with other central nervous system symptoms, but a normal MRI, you say that not all of these tumors show up on an MRI. What then?
At that point, I would definitely discuss this with a neurologist, because if you have that kind of significant symptoms, a small microadenoma that can't be seen is probably not the cause of your headaches. But definitely talk to a neurologist, and also, you'd want to rule out other syndromes like Cushing's disease, but you'd probably talk to your primary care doctor about that first.
Okay, I have a 5 millimeter non-secreting pituitary tumor and atypical bilateral trigeminal neuralgia in all three branches. I have intense pressure in both ears and in my head 24/7. None of my doctors can explain why I have this pressure. I'm on 2,700 milligrams gabapentin.
Sorry, they're calling me from the operating room. Can you repeat that question again?
Yes, sorry about that. I have a 5 mm non-secreting pituitary tumor and atypical bilateral trigeminal neuralgia in all 3 branches. I have intense pressure in both ears and in my head 24/7. None of my doctors can explain why I have this pressure. I'm on 2,700 milligrams gabapentin.
Yeah, I don't think the pituitary adenoma, being that small, would be able to cause bilateral trigeminal neuralgia. I think there's something else going on. I would definitely recommend a neurologist who specializes in trigeminal neuralgia or facial pain. If the medications aren't cutting it, there are some other options, but removing the pituitary tumor, it would probably not help with your headaches.
Okay. I had surgery for acromegaly in 1997 and have been on Sandostatin LAR 20 milligrams since. Recently, I was unable to get this shot for 2 months and got a severe headache. I was admitted to the hospital for 2 days and many tests, including growth hormones, concluded that there was no reason for the headache. 2 days later, I got the Sandostatin LAR 20 milligram shot and my headache went away. Could the lack of injection have been the cause of the headache? If so, any suggestions that I can present to Medicare so this won't happen again?
I mean, it certainly makes sense based on what you've said. It certainly fits with your clinical scenario. I don't know if you've been evaluated by an endocrinologist in the interim and what type of tests they had done, but you may want to look into that a little bit further. The only other way to prove it is to stop it again and see if your headaches come back, and if it resolves again, then you'd have a pretty convincing argument there. But again, I think that falls into line that you may have a direct link there. There may be also a correlation being on it for so long, just the dopamine levels are being affected by the sandostatin, and then all of a sudden you lose that effect. That actually may contribute as well. But now that's kind of a guess, and I'm not basing that on any hard evidence.
Okay. Have pituitary tumors or meningiomas and hydrocephalus been linked to Parkinson's?
No. Parkinson's is a different type of condition. It's a degenerative condition, and we have seen Parkinson-like syndromes with trauma or other structural lesions, but not really from a tumor in the area.
Okay, I have acromegaly surgery to remove macroadenoma 8 years ago. Surgery did not remove tumor. I still have regular headaches and have tried a number of medications and I'm kind of just accepting it now. I guess more than anything, I just want to know if this is abnormal.
It sounds like it fits with the syndrome. I'm not sure if you're on medication to help treat your acromegaly, but certainly that could help get your disease in control, and we'd like to see if your headaches get improve with that.
Can hydrocephalus pressure ever be relieved by a CSF leak through a fistula between maxillary sinus where infected tooth has eroded jaw?
That's an interesting question. So that's not the way you'd want to relieve hydrocephalus, but we certainly have seen CSF fistulas as a result of elevated intracranial pressure that comes through the sphenoid bone. And I haven't seen it in the maxillary sinus, but I have seen it in the sphenoid sinus. That would require surgery to fix it, but it doesn't solve the issue of the hydrocephalus. So you'd want to get that evaluated by a neurosurgeon, and also you may want to make sure that it is CSF or cerebrospinal fluid that's leaking in that area, and seal that up before it becomes an infection.
Okay. Can the use of the Mirena IUD releasing a synthetic hormone over the course of 5 years contribute to the development of a pituitary microadenoma?
I don't think so. Usually they are coated with progesterone type of hormone, and I don't think that in itself can induce an adenoma. That would be highly unusual.
Okay, I think that covers all of the questions we have, and we're getting past our time frame here, and you're getting calls from the OR, so I think we will wrap it up. This concludes our webinar presentation. If we did not get a chance to answer your question, we'll be answering them via email. The P&A wishes to thank you for participating in our webinar. There'll be a brief survey at the end. Please fill that out to help us provide you with the information you need. I did have a question about whether or not this will be available after. It has been recorded, and after a little bit of editing and some converting, it should be available on our website tomorrow. So if you missed it or you have someone else that you want to have watch it, it will be available probably by tomorrow afternoon. If you have any questions, you can contact us at webinar@pituitary.org or give us a call at 805-499-9973. And we're getting a bunch of little messages. Thank you, and awesome conference. And so we definitely appreciate your time, Dr. Barkhoudarian, and all this great information that you provided for us. Thank you so much. This concludes our webinar, and until next month when we'll do this again. Thank you.
Thank you. Thank you for having me.